All right, pancreatitis. There's some interesting stuff here in pancreatitis. You might not think so. So can a patient with pancreatitis have a normal, near or normal amylase? One of the messages in this 30 minutes is the answer is absolutely. Because a lot of us think, well, we'll diagnose pancreatitis when they have a 3-time normal amylase, 3 times normal lipase. We've kind of picked that number kind of thing. And the data is, yes, if you have something that's 3 times normal in your amylase or lipase, the diagnosis is pancreatitis. It's very rare that some other cause would generate that kind of amylase or lipase. So, but the other message here, which is actually more important, is how many people will have pancreatitis with a amylase or lipase that is less than 3 times normal? Obviously, it must occur. And so what is the issue here? So the first 5 papers all basically say you can have pancreatitis with a normal or near normal amylase. You can. How often does this happen? One paper said 8%, another paper said 19%, another paper said 21%. So it certainly would not be rare. It is not the rule, certainly, but it is not rare. One of the problems with these papers is, what is the gold standard for making diagnosis of pancreatitis? Well, I think the answer is probably CT. I hate to say that, but you know, you take a person and you can see their pancreas is edematous, and you can see the loss of fat planes in the pancreas. They have a clinical history consistent with it, and you can say, okay, that's pancreatitis. Or another way to make a diagnosis, and I'll show you those papers, is where they do it in an autopsy. Generally not the best way to make the diagnosis, but these are people who died. There's a paper here, 5% of people had pancreatitis. They didn't have the diagnosis made, and they died. Before they died, they did an autopsy, and they said, there's the problem. You got pancreatitis, because we'll see that it is a multi-system disease. When you're going to die from it, it basically takes out all your organ systems because of all of those proteolytic and lipolytic enzymes in your bloodstream, basically, myocardial depressant factor, ARDS. You die of a multi-system condition. So in any case, this issue about can you have normal, near normal amylase in pancreatitis is paper number 1 says, well, here's an example, recurrent pancreatitis. Now, we all know that people who have recurrent pancreatitis, the diagnosis has been made umpteen times before. They come in again, they seem to have the same symptoms, and they are not entitled, or they may not have a high elevation of amylase or lipase, because the idea is the pancreas is all burned out. It's not making these juices, putting it into the bloodstream, etc. So that was number 1 cause. Number 2 cause is like alcoholic pancreatitis. But in the study of a little adults going by, in the study where they did the postmortems and they found that every cause of pancreatitis that we know of can be associated with normal, near normal amylase or lipase in that diagnosis. One of the papers here that is in this cluster of the first 5, they compared lipase levels and amylase levels, and they concluded that the sensitivity for a lipase was better, and I think that that's true. I mean, most of us don't do amylases anymore. We swapped out lipases a while ago. It stays up longer. It is more sensitive for the diagnosis. Both of them are quite specific. If you have a 3 times normal lipase or you have a 3 times normal amylase, no matter what, either one, specificity is like 98% once you hit that threshold. One of the things that is discouraging, but is a recurrent phenomenon in literature, is that the severity of pancreatitis is not reflected in the level of the lipase or amylase. So you can have a nasty case of pancreatitis with this normal, near normal, or even die from it, and that's reflected in here. Number 3, 5% of all cases had the diagnosis of pancreatitis made at autopsy, and they had normal amylase levels. And since the height of the amylase does not reflect the severity, you can say you could have nasty pancreatitis and a marginal or you know, in essence, marginal level of your amylase or lipase. So those two disconnects make it clear that you could, just because amylase only bumped a little bit doesn't mean this person may not have this disease and may not ultimately crump from it. The paper I like here, the best of the 5, is number 5. It says, okay, let's look at this threshold of 3 times normal amylase. It says you'll miss a lot of cases. Using this criteria, 3 times normal amylase, to make the diagnosis, you'll pick up half the cases. Half the cases. Now, I don't know if that's really, really true, but it says 54% sensitivity. Meaning it missed 46% of the cases. And when you look at 3 times normal lipase, sensitivity was 77%. It picked up 3/4 of the cases, missed 1/4 of the cases. Missed 1/4 of the cases because they had lipases below this. Again, this points out the specificity, how great it is. Once you hit that level, they got pancreatitis. And they point out that it's a rare condition that would cause a 3 times elevated normal amylase or lipase that is not pancreatitis, 1 or 2%. And what are some of those conditions that could cause an elevation of that magnitude? That's addressed in papers 5 through 10. All of these papers, you have to wonder, what is the gold standard that they're saying the amylase is elevated, but it's not from pancreas, it's from some other disorder? Because not all the time did they necessarily do CT to make the diagnosis. So you have to be a little bit careful. Number 5 says 13% of the cases of elevated amylase in that paper were due to extrapancreatic causes. Here's the list. So they got small bowel pathology. Small bowel pathology. What is that, like a bowel obstruction or some inflammatory condition or something like that? Biliary disease. Well, how do you know biliary disease is not also a little pancreatic disease? Maybe get a little stone in the common duct amplifier kind of thing. We were told gynecological conditions. Fallopian tubes supposedly have amylase in them, and so that maybe you could get a bump in your amylase from a gynecological condition. But paper number 6 says we got 80 women who have gynecological conditions, and not one of them had an elevated amylase. Number 7 said gastroenteritis. Well, how do you make the diagnosis? There's no gold standard for gastroenteritis at all, for crying out loud. No gold standard. Gastroenteritis. Gastro means you're vomiting. Enteritis means you're diarrhea. That's the diagnosis. And then this paper, number 7, said 7% of the people who had gastroenteritis as a diagnosis had elevated amylases. I'm not so sure that I would believe that, but the more compelling papers are number 8. This is 192 ICU patients, and they measured their amylase in these patients. 1/3 of them had elevated amylase levels. As an example, 40% of isolated head trauma had elevated amylase. 43% with isolated chest trauma, 44% with abdominal trauma. Weren't we supposed to, in the trauma centers, measure amylase in trauma patients to see whether they have is that a screening test for a pancreatic trauma? Every paper that has looked at that, every paper says there's no relationship between the amylase and whether you have pancreatic trauma. Yet we continue to put that into this panel of tests that we send over to the lab from the trauma cases. And the fact of the matter is that these amylases are not coming necessarily from any injured pancreas. You can have it from chest trauma, head trauma, belly trauma. 1/4 of the people in the ICU who had a coronary artery bypass had elevated amylases, and 29% of other conditions. Now, what kind of amylases were they? So they fractionated the amylases in this study here. 17% had both pancreatic and non-pancreatic amylase. 1/4 of them had pancreatic amylase, and 57%, the majority, had non-pancreatic isoamylase elevations. So where's this coming from? It's coming from the, salivary glands. Sometimes they can't even identify where it comes from. But the fact is, it is not necessarily pancreatic, and in fact, this paper says it's the minority of cases. So just because somebody has some kind of trauma does not mean, for whether it be head, chest, belly, that they have a pancreatic injury. Literature does not support that as a screening test for pancreatic injury at all, if we were to get into trauma literature specifically. What about elevations in intoxicated patients? This is good information to know. So you have a person who's intoxicated in the department. You want to get them admitted to the hospital. Just tell the admitting doctor they have pancreatitis. Yeah, that's usually a bona fide admission criteria. Come in the hospital, this alcoholic, they get vomiting, belly hurts a little bit, probably pancreatitis. Common cause of pancreatitis, yes. So you just tell the doctor they have pancreatitis, and that problem, it goes out of your hands and into somebody else's hands. But if you had the capacity at your hospital to fractionate amylase to where did this amylase come from, you would never ever want to do that in these cases. Number 9, 58 intoxicated patients. 30 of them had elevated amylases. Oh, that's good. In 25, it was non-pancreatic. It was salivary and 25 of the 30. In 3, it was pancreatic and non-pancreatic. Now here's cool. 9 patients had signs and symptoms suggestive of pancreatitis, and none had an elevated pancreatic isoamylase, and 6 had elevated salivary amylases. So just tell them it's pancreatitis. Get them out of there, and they'll be fine because it's not pancreatitis. According to this paper, at least half the cases will have asymptomatic elevations in their amylase. Number 10 says we looked at 174 intoxicated patients, and in this study, only 9%. In the prior study, half of them had elevated. In this study, only 9% had elevated amylase. That was 16 people. 7 were due to salivary amylases, 6 were due to pancreatic, 1 was due to both types, and 2 had neither pancreatic nor salivary fractions elevated, but the total was elevated. So basically it says a lot of intoxicated patients will have elevations that don't necessarily mean that they have the disease, but you should say they do. So get them admitted to the hospital, get them out of there. Or yeah, exactly, to frighten them. You know, your pancreas is dissolving itself right now as we speak because of your drinking issues here. And here's the number, right? Just show them the, well, you don't have to show them their number, show them somebody else's number. Look at your number. Look at, this is good. Well, you can do that to people who have, you want to stop them smoking. They talk about this, what a teachable moment kind of thing, a teachable moment. So just show them somebody else's x-ray, you know, when they're coming in there with that bronchitis. And you know, look at this, what a mess this thing is here. You better stop now. The role of lipase in making the diagnosis, that's 11 through 15. And we already kind of covered this stuff. Here's all the papers that say this is the preferred test to measure the, in these cases. They also talk about, in the bottom here, they talk about urinary trypsinogen. Urinary trypsinogen, here there's a paper, number 17. In 1998, they were talking about urinary trypsinogen. And lo and behold, now there's a study done out of UCLA in the University of Washington, Washington University. That's number 16, Academic Emergency Medicine, published in January of 2007, about a urine test, point-of-care urine test for making the diagnosis of pancreatitis, where you're measuring whether you have trypsinogen in your urine. This is a finished product, not available yet in the United States, but this study was done at UCLA. 191 patients with symptoms suggestive of pancreatitis. And they tested their urine, this 3-minute dipstick test here. 17 of the 191 were diagnosed with pancreatitis. The pancreatitis diagnosis was what the doctors diagnosed at the final. They looked at the record, looked at the CAT scan. Here's our diagnosis. So 17 patients were diagnosed. Final diagnosis was pancreatitis, and all of them had a positive trypsinogen test. It was 100% sensitive. It picked up every case of pancreatitis. Now, unfortunately, another 7 people out of this large study of 191 people had positive trypsinogen tests, but they didn't have pancreatitis. 4 of them had renal failure, so okay, well that would probably be now we know maybe you can't do it in that setting. And 2 had pancreatic pathology confirmed on CT. Not pancreatitis, but they had other things wrong with their pancreas. Here's something interesting. So 17 people basically had pancreatitis. 7 of the 17 diagnosed with pancreatitis when they left the hospital had diagnostic findings on CT and a positive trypsinogen test and negative and non-diagnostic amylase and lipase levels, reaffirming that you cannot depend on that 3 times normal to pick up. Cases will have it below. 7 of the 17 had non-diagnostic amylase and lipases, despite the fact that they had a positive CAT scan and a positive urine trypsinogen. So this is a backdoor way of reaffirming that you should not feel, no, that's only a modest elevation of amylase, lipase, probably isn't pancreatitis. You can't necessarily say that with a lot of confidence. In this study, the sensitivity of the plasma lipase was 50%, and the specificity, again high, 99%, when it was 3 times normal. But the amylase was only 41%. Picked up 41% of these cases. Missed the others. This is not as good as the numbers that I showed you before, where lipase was 77% sensitive, and amylase was about 53% sensitive. This is even worse. Is the gold standard for measuring this? Yes. CT is the imaging study here. And they've been measuring this thing for a long time. Like here's an old paper, 18 is an old paper, Clinical and lab, there's a study, San Francisco General, 36 cases of suspected pancreatitis. Ultimately, 33 of the 36 had it. Clinical and lab data made the diagnosis in 25 of the 36. Clinical and lab made the diagnosis of 25 of the 36. CT made the diagnosis in 8 of the remaining 11 cases. 8 of the remaining 11. And it excluded it in 3 cases. So the typical findings that they say is the pancreatic enlargement and obliteration of the peripancreatic fat planes, whatever they are. 20 and 21 basically go back to, and should have been included in the beginning, about these people who die of pancreatitis. 53 autopsy cases. You talk about lethal pancreatitis as undetected as a diagnosis before death. And they say undue reliance on amylase and lipase is the problem. So that's kind of the message of this talk. They say pain may not be present or only mild. They say pain may develop in patients who are already in the hospital, like on ventilators. They're not going to tell you very much. It may develop in the immediate post-surgery setting. All usual causes of pancreatitis can be fatal yet occult. So it wasn't just about the recurrent relapsing alcoholic pancreatitis or that version, no. Pulmonary congestion was common, especially in those in renal failure. And we'll talk about the manifestations. Actually, that's next. 22, 23, 24 all talk about the manifestations of severe life-threatening pancreatitis. You know, they had that ransom score kind of thing about measuring clinically how bad your pancreatitis may be by this score. This basically says your calcium can go down because pancreas is alkaline, secretes these alkaline juices into the duodenum, ample water kind of thing, neutralizes the stomach acids to put the alkaline pancreatic juices. Calcium precipitates in an alkaline environment. In this setting, these enzymes, amylases, lipases, trypsinogen, all of this other stuff is basically leaking out of the duct system of the pancreas into the tissue of the pancreas. And so in chronic relapsing pancreatitis, you take a flat plate and you see all of this little punctate calcium over the pancreas from the precipitation of calcium in the alkaline medium of the pancreatic juices. So you can become hypocalcemic. You can have low albumin from like a tissue burn kind of thing where all of this fluid is sequestered in the retroperitoneal area where the pancreas is as a result of this inflammational process. You can have high sugars and low sugars because of pancreas cranking out insulin, more likely to be high sugar than low sugar. DIC, because these things in the bloodstreams, these amylases, lipases, and trypsinogen, can trigger the DIC process, and you get these microclots formed that shower through the capillary system of the lungs and kidneys and those kinds of things, so ARDS. You can get shock from plasma loss. You can have myocardial depressant factor, whatever that is. It's been found to decrease pumping power of the heart. So you have a multi-system disorder that basically kills you at the end. Treatment, GI suction. It doesn't work. Every paper that looked at it says it doesn't work. The theory is good. Theory is we'll suck out the gastric juices, suck out those things because they are the stimulus for the pancreas to secrete. And if the ducts are blocked up for whatever reason, the edematous is swollen in the pancreas, we'll put the GI tract at rest. We're going to suck out this stuff from the stomach, decrease the stimuli to make the pancreas secrete, and everything will be better. And that's the theory, but the fact is the theory didn't work. Now, I love the title of number 25. You want to do what, doctor? You want to put that where? Modern indications for nasogastric intubation. No benefit in a lot. Well, there's no benefit in a lot of things, but specifically, it's no benefit in this condition. There was a study that we have in our database about what procedures patients like the least, and NG tube was at the top. Have you ever had an NG tube? Nah, it's no fun kind of thing, you know. I'd rather have something else. But so when I was interviewing for medical school in Philadelphia, Philadelphia's got a lot of medical schools. It's got Pennsylvania, University of Pennsylvania, Jefferson, Temple, Hahnemann, 4 big medical schools right downtown kind of thing. So I lived there. And I interviewed at all those medical schools. And I went to Jefferson, University Jefferson, and They basically said, oh, yeah, it's a great place, yeah, a wonderful place. I went and walked around, and they said, yeah, here's our lab here. We pass NG tubes on each other, and it's part of our training program. I go, okay, scratch Jefferson off to get the hell out of there kind of thing. I'm not putting any NG tube down myself or to my neighbor either. So that was scratched off. Every one of those papers, if you read the conclusion, basically concludes that theoretical thing doesn't really work. And in fact, some of them throw in a few other benefits. Like number 28 said, why don't we throw in cimetidine? Does cimetidine work? Well, cimetidine, same theory. Cimetidine decreased the acid in the stomach to produce less of a stimulation for the pancreas to secrete. So giving cimetidine did not work. In fact, the authors concluded that cimetidine appears to prolong hyperamylasemia and abdominal pain associated with acute alcoholic pancreatitis at least. So every one of these papers says, no, it didn't work. What about drugs that would decrease? So number 32, 33, 27, and 28. Glucagon didn't work. Atropine didn't work. Cimetidine didn't work. NG tube doesn't work. So the only indication for an NG tube in a pancreatitis patient would be somebody who's got recurrent vomiting and cannot otherwise be controlled. One of the things that I thought may be helpful by ER doctors is to identify pancreatitis and give them antibiotics. This idea of prophylactic antibiotics in pancreatitis, because in the subset who die, they generally are septic in the process. So I thought, let's look at the papers on that, because that might be a good thing to do. Well, it turns out that sepsis is the most common is common in the subset of people who get necrotizing pancreatitis. What is that? Necrotizing pancreatitis means your pancreas is rotting, and not all pancreatitis is associated with necrotizing pancreatitis. So the numbers are 15 to 30% of pancreatitis patients will have evidence of necrosis of the pancreas. And in that subset, that 15 to 30%, they are prone to getting septic. Up to 70% of the people who have necrotizing pancreatitis can become septic. So, and you don't know who they're going to be yet, so you're just seeing them in the ER. You're not sure where that evolution is going to go. So maybe you give them some antibiotic, and maybe you'll kind of abort or mitigate that sepsis that may be down the road for some subset of them. Necrotizing pancreatitis is discernible on a CT with IV contrast, so the papers say there. And so the first two studies sounded like it was a good idea to give a pancreatitis patient some antibiotics. Like number 4, an old study, 1995, they noted that infectious complications developed in 2/3 of the patients receiving prophylactic antibiotics and 85% of them not receiving prophylactic antibiotics. And there were multiple other markers of the sense that antibiotics may be useful, like the mortality, 3% versus 28%. But these are associations again, not causality. And 35 was a kind of a positive. They said maybe it's a good idea because you're not going to get a CT right away in all these pancreatitis patients. And so that might be down the road a bit, and you're not going to see necessarily the development of necrosis right away. So in this study, 59 of 215 patients ultimately developed necrosis, which was about like 30% of them developed necrosis. Of those, 30 got antibiotics early, and 29 got antibiotics late. And extrapancreatic sepsis, 5 of 30 who got antibiotics got sepsis, 5 of 30. And those who got, that was early antibiotics, and those who got late antibiotics, 13 of 29. So that sounded like it was basically an advantage to be given early. Length of stay in the hospital, 18 days versus 30 days. Well, both of those lengths of stay are very long. 3 deaths in each group. So again, it suggests that maybe there was some benefit of giving some broad spectrum antibiotic. In this paper, they gave meropenem. And the last 2 papers are supposedly against the idea. But in fact, if you read number 36, it could be interpreted just the opposite. 36 is a meta-analysis of 6 randomized controlled trials published in 2006. He said, you know, there are methodologic problems with the studies in half the cases, but despite that, we're going to include them in our analysis. And they said there were clear trends to better outcomes with early antibiotic prophylaxis, like, as an example, the relative risks for the outcome of infection was 0.77. Well, it means it was down, it was decreased by 23%, relatively speaking, this idea of infected necrosis. Mortality, relative risk, 0.78, 22% down. Non-pancreatic infection, 30% less. Surgical interventions, relative risk, 0.78, less than 1. So all of those things implied that maybe this was a good thing to do. 4 studies showed shorter lengths of stay with early antibiotics. So this paper, although the conclusion says it's not that good a deal, it sounds kind of more positive than not to me. But unfortunately, the most definitive paper on this is the one number 37. 100 patients with documented severe necrotizing pancreatitis. To get 100 patients with severe necrotizing pancreatitis means that you had to start out with 300 or 400 or 500 patients with pancreatitis in general to get this subset that is going to have necrosis. And they randomized them to IV meropenem or placebo. The treatment duration was about 10 days. There's no significant difference in the outcome. The mortality, 20% versus 18%, not statistically significantly different. So basically it shows once you get necrosis, 1 in 5 of you will die, kind of thing. How many people get necrosis? Between 15 and 30%. So this paper was the randomized controlled study, and basically showed there was no difference in terms of the early use of antibiotics. Do you, any of you, have any beliefs or behaviors related to what are you going to do for these pancreatitis patients in terms of this or any other issue? Anybody give antibiotics? Well, then you'll cite paper number, the last paper there, because that's why you don't do it. You're right on top of the literature. It's like a stop clock is right twice a day. What clues, this last 38, 39, and 40 is about gallstone-related pancreatitis. This makes it clear that everybody who has pancreatitis should have a gallbladder ultrasound. Because ultrasounds, 70% of people will have stones. Talks about what blood tests will be more abnormal in the setting. Not that it's going to matter to you that particularly much, but higher alk phos, higher bilirubins, higher SGOTs and PTs. They call it AST now. What is AST? You know, aspartate aminotransferase, aspartate. Actually, that's SGOT for the older doctors. And higher ALT, alanine aminotransferase, that's SGPT for the older doctors. So those tests will probably be helpful. But bottom line is, everybody who you think has pancreatitis, while they're there, it's generally pretty easy in the emergency department to get an ultrasound if it's between 9 and 4:30 in the afternoon. Any of you newer, younger doctors do ultrasounds yourselves of gallstones and that kind of stuff? You younger doctors, you know how to do that kind of stuff? You're not all that younger doctor. How come you did? Damn. So did you take a course to learn how to do ultrasound? 3 of them. You took 3 courses. And how do you get the confidence? You just kind of, well, gallstones are probably not something where it's kind of late. It's not life and death. And
the one that finally got it to get it pushed through into use was ectopic pregnancies. We had a few long delays on people who sanguinated. Pretty soon our OBs just said, get an ultrasound machine, start doing ultrasound for possible ectopics. We want to know now. And that pushed it through, and we finally got it for ectopics. And once we got it there,
Joe, all these younger doctors going through these residencies, I mean, the stethoscope, the stethoscope is going to be history. It's going to be in the museum. It's a stethoscope. They wear these probes around their neck now, you know, walking down the hallway. All right.